Hello everyone, welcome back. In this video, we are going to study about the imaging anatomy of ankle and foot on both X-ray and MRI. So let's see. So the flow of presentation would be like first we are going to study about the anatomy of ankle and foot on X-ray, followed by MRI. And we are going to, on MRI particularly, we are going to divide the anatomy into four parts, which is osseous anatomy, ligamentous anatomy, anatomy of muscles and tendons, and nerves and vessels. So let's just first have a look at the osseous anatomy of ankle and foot. So here we are looking at the AP projection or AP view of the ankle where we can see lower end of tibia and fibula. And this is the talar dome, and we can see articulation between the lower end of tibia and talar dome forming ankle joint proper. This is an oblique view which is showing again anatomy of osseous anatomy of the ankle and foot, where we are seeing lower end of tibia and fibula. This is talus. This is a small cave-like area which is sinus tarsi. This is calcaneus. This is cuboid, and these are other cuneiform bones. This is navicular. These are metatarsals, and these are phalanges. This is a view from posterior aspect where we are again seeing the lower end of tibia, talus, calcaneus, fibula, and the other tarsal and metatarsals bone. So we can divide the entire foot in three parts, that is forefoot, midfoot, and hindfoot. So hindfoot is formed by two bones, that is talus and calcaneus. Midfoot is formed by navicular and the three cuneiform and cuboid bones. So cuboid bone is laterally, which articulates with the calcaneus. Navicular bone articulates with the talus. And these are the three cuneiform bones: medial, intermediate, and lateral cuneiform bone. And these four bones, they articulate with the base of five metatarsal bones. And these metatarsal bones then articulate with the respective proximal phalanges of the toes. So the metatarsal and the phalangeal bones, they form the forefoot. Midfoot is formed by the tarsal bone other than talus and calcaneus, and hindfoot is formed by talus and calcaneus. So this graphic is again showing different bones in the foot. One more thing which is important in the foot is the arches. So we have two important arch, which are lateral and medial longitudinal arch. So the lateral longitudinal arch is formed by the fourth and fifth metatarsals, cuboid, and the lateral part of calcaneus bone. And medial longitudinal arch is formed by the medial three metatarsals and the cuneiforms, navicular, talus, and calcaneus bone. So these are important for maintaining the plantar arches. Now let's see the X-ray anatomy. So before proceeding towards the anatomy, we should have a basic idea of how many views we use generally for ankle. So ankle radiographs are basically commonly advised in emergency department, generally after trauma. And the radiographic series of the ankle comprises of three views, that is anteroposterior, mortise, and lateral view. So these are the three views. We have first AP view, followed by mortise and lateral view. So what is the difference between AP and mortise view is that in mortise view, AP view is basically in the normal anatomical position. And in mortise view, we have slight medial rotation of the foot so that this lateral and clear space, it becomes evident, and there is no overlap between the lower end of fibula, that is lateral malleolus, and the talus. So here we are able to see the entire tibial plafond. So this is mortise view, and this is the lateral view. So it is important to cover the base of fifth metatarsal in the AP and mortise view. Why? Because this is the common area which is involved by trauma when it affects the ankle joint. So most common traumatic injury that affects ankle is the inversion sprain, and in that inversion sprain, it can cause fracture of the lateral malleolus as well as fracture of the avulsion fracture of the base of fifth metatarsal. So it is important to include this part in the radiographic view. So this is how we acquire the AP, mortise, and lateral view of the ankle. So in AP view, you can see this is the collimated area, and this is the centering. And these are the parts which are covered in the AP ankle view. In internal oblique view or mortise view, there is slight internal rotation of the foot. And this is how we take the mortise view. In lateral ankle view, we take this in this way. So this is the AP radiograph of the ankle, which is showing lower end of tibia and fibula. This is the ankle joint proper or talar dome articulating with the lower end of tibia. This is medial malleolus, this is lateral malleolus, this is malleolar fossa, and this is the tibiofibular synchondrosis. So what can happen when we don't take the radiograph properly? There can be insufficient medial rotation, which can lead to more overlap between the tibia and fibula and talus. There can be insufficient dorsiflexion, which can lead to calcaneus being projected over the ankle joint. This is the annotated lateral radiograph of ankle, which is again showing lower end of tibia and fibula. This is talus. This is the ankle joint proper. This is navicular. This is medial cuneiform. This is the head of first metatarsal. This is calcaneus. This is the talocalcaneal joint, posterior talocalcaneal or subtalar joint. This is posterior tubercle of talus, and this is the promontory of the tibia. Now let's see how we take radiograph of the foot. So this is the dorsiplantar foot technique. So here we just keep the patient's foot like this, and we take radiograph in this way. And there is another projection, that is medial oblique view of the foot, in which we slightly rotate the foot medially. And it is an extremely important view to assess the lateral foot pain, which shows the cuboid and the fifth metatarsal. We can also take a weight-bearing lateral radiograph of the foot, and without weight-bearing, we can also take a lateral radiograph of the foot. So this is the annotated radiograph of dorsiplantar view of the foot, where we can see all the metatarsals 1 to 5. We can see all the phalanges of the toes. So first is the great toe, where we have proximal and distal phalanx. And then we have other 4 toes, where we have proximal, middle, and distal phalanges. We have metatarsophalangeal joint, and we can have 2 or more than 2 sesamoid bones. Generally, we see these 2 sesamoid bones at the head of fifth metatarsal. We can also see multiple other sesamoid bones around the head of other metatarsal bones. These are cuneiforms, and this is the cuboid. This is navicular. This is the head of talus, which is articulating with navicular bone. This is calcaneum, which is articulating with cuboid. And here we can see the lower end of tibia and fibula, medial and lateral malleolus. This is the oblique view of the foot, which is again showing same findings. And here we can see a better view of the fourth and fifth metatarsal and cuboid without much overlap. So it is important in cases of lateral foot pain. This is the lateral radiograph of the foot, where we can see longitudinal plantar arch, all the 5 metatarsal bones, but they are overlapping each other. This is the sesamoid bone, and these are bones of the phalanges. Again, tarsal bones overlapping with each other. In this view, we can have a better look of the calcaneus and the subtalar joint. So, and of course, at the posterior malleolus, and the we can have slight view of the lower end of tibia articulating with talus. We can have a special projection for toes if in patients with metatarsalgia and pathologies which are specifically affecting the toes. So we can just collimate in that area, and we can take radiograph of that particular region. So this is how we take dorsiplantar view of toes, both in dorsiplantar view and slightly oblique projection. This is how normal dorsiplantar projection of toes look like. So again, we are having a closer look at the toes to identify any subtle abnormality here. We can also focus on one toe, and we can take projection of that particular toe only, or we can take axial projection of the sesamoid bone in cases we are suspecting pathology affecting sesamoid. This is the axial projection of the calcaneus. So this is important in case we are suspecting calcaneal fracture or any space occupying lesion in the calcaneus. And this is how we take axial projection of the calcaneus. This is the lateral projection of the calcaneus, and again we are having a closer look at the calcaneus and the bones which are articulating with it. An important measurement that we take in lateral projection of calcaneus is the Bowler's angle, and this is how we take Bowler's angle. So we point out three highest points on the superior surface of calcaneus, and we draw two tangential line along them, and the angle from them is measured posteriorly and it is assessed. Normally it is 30 to 40 degree. If it is less than 28 degree, then it is abnormal and it indicates fracture or flattening of the calcaneus. Now let's move to the MRI anatomy. So let's first have a look at the osseous anatomy. So this is the lateral view of ankle where we are scrolling. So this is actually sagittal plane, PDFS sequence, and we are scrolling from medial to lateral, and we are seeing this lower end of tibia articulating with talus, and beautiful ankle joint which is from this hyperintense structure is articular cartilage. So here we can see talus is articulating with navicular bone. This is calcaneus, and as we are moving posteriorly, we can also see here laterally sinus tarsi, and this is the subtalar joint which is formed between talus and calcaneus. So we are moving laterally and we can see lower end of fibula or lateral malleolus. This is the coronal view where we are seeing the again same osseous anatomy, lower end of tibia articulating with the talus, and lower end of tibia and fibula both, and the syndesmosis. So this is the axial view. So as we are moving down, we can see two bones of the leg, tibia and fibula. And as we are moving down, we can also see the syndesmosis between them. There shouldn't be an abnormal widening here. Then there comes the talus. This is medial malleolus, this is lateral malleolus, this is talus. And as we move down, we can see entire talus here, and talus articulating with the navicular bone. And this is calcaneus articulating with the cuboid. This is the osseous anatomy of the foot, where we can see again talus articulating with the navicular bone. Here we can see three cuneiforms. This is calcaneus, this is cuboid, and these are the metatarsal bones. This is the fifth metatarsal, fourth, third, second, and first, and these are the toes. Now let's have a look at the ligamentous anatomy. So moving towards the ligaments, we have high tibiofibular ligament, which are anterior and posterior syndesmosis and the interosseous ligament. Then we have lateral ligaments, lateral ligamentous complex, which includes anterior talofibular, calcaneofibular, and posterior talofibular ligament. Then we have medial ligamentous complex, which is basically deltoid ligament and its components. Then we have sinus tarsi ligaments, which is formed by the extensor roots, interosseous ligament, and cervical ligament. And finally, Willis Frank ligament. So we are going to have a look at all these ligaments. So let's just first see how tibiofibular ligaments attach. So basically, as the name indicates, these ligaments, they connect lower end of tibia with fibula. So this is the posterior talofibular and this is the anterior tibiofibular ligament, and this is the syndesmosis, and here lies the interosseous membrane and interosseous ligament. So these are anterior and posterior tibiofibular ligament because it connects the tibia with fibula. Then comes the lateral ligaments, which are anterior talofibular, calcaneofibular, and posterior talofibular ligament. So we'll look them one by one. So what is this ligament? Because it is connecting fibula with talus. So this is talofibular ligament and it is anterior. Then we have posterior talofibular ligament because it is connecting fibula with talus. Then we have calcaneofibular ligament which connects fibula with the calcaneus. Medial ligamentous complex is quite complex as the name indicates because it has superficial and deep component. So the deep part of deltoid, which is rectangular, it consists of the small anterior component, that is anterior tibiotalar component because it connects tibia with talus, and a strong posterior component, that is posterior tibiotalar component because again it connects tibia with talus. So the deep part of deltoid is most important when we talk about its contribution towards ankle stability. So deep part of deltoid is more important than the superficial part. The anterior and posterior tibio-talar ligaments constitute the deep part of deltoid. Then comes the superficial part of deltoid, which is formed by tibio-navicular ligament, tibio-calcaneal ligament, and tibio-spring ligament. So tibio-spring ligament is basically attaching lower end of tibia with spring ligament. So what is a spring ligament? Spring ligament is calcaneo-navicular ligament which connects calcaneus with the navicular bone, and so that's why its name is tibio-spring ligament. And spring ligament is very important in maintaining the longitudinal arch of the foot. Posterior tibio-talar ligament represents the strongest part of the entire medial ligamentous complex, and the deep portion is basically covered by synovium and it is intra-articular. Now let's have a look at these ligaments one by one. So as we are moving down, we can see this axial view and we can see the tibia and fibula and the space between tibia and fibula. As we move down, this space decreases, and here comes the posterior and anterior tibiofibular ligament or high tibiofibular ligament. As we move down, we will just focus on lateral ligaments first. So as we move down, we can see there is a ligament which connects the lateral malleolus with the talus. So this is anterior talofibular ligament. And there is another ligament which connects the this posteriorly. So that is posterior talofibular ligament. So here we can see anterior as well as posterior talofibular ligament. And we can also see this is the these are peroneal tendons, and the ligament which goes from the lower end of fibula or lateral malleolus to the calcaneus. It just travels deep to the peroneal tendon, and this is the calcaneofibular ligament. So these were the lateral ligaments. Now let's see the medial ligaments. So as we move down, this is the medial malleolus, and here we can see the hypointense ligamentous structure, which is deep to the tibialis posterior and flexor digitorum longus. So these are the components of deltoid ligament. And this is the spring ligament, which lies just deep to the tibialis posterior tendon. Now let's have a look at these ligaments in the coronal plane. So here we can see lower end of tibia and fibula. And this is the attachment of anterior talofibular ligament. And this ligament is going to attach posteriorly at the fibula. And we can also see these are the peroneal tendons, and there is a hypointense ligament which is going just deep to the tendons, that is calcaneofibular ligament. And as we go posteriorly, we can see this posterior talofibular ligament, which shows anisotropy, and it often looks hyper intense. So don't misinterpret as sprain or tear, because it is very rarely torn, posterior talofibular ligament, and it will be torn only if anterior talofibular ligament is also involved. So in isolation, you won't find sprain or tear of posterior talofibular ligament. So abnormal hyper signal intensity in it is it's normal. These are the different components of deltoid ligament complex, which actually lie just deep to the flexor tendons. This is the sinus tarsi, which is an abnormal, which is a cave-like structure on the lateral side of the ankle, and the space between talus and calcaneus. So normally it is filled by fat and some ligaments, and you won't find much signal intensity in it. But sometimes in sinus tarsi syndrome or in other cases when ankle is involved, you can find hyperintense signal in this area, and space occupying like lesions like ganglion cyst and other structures. So the ligaments which form sinus tarsi ligamentous complex is interosseous ligament, cervical ligament, and inferior extensor retinacular roots. Lisfranc ligament is very important in maintaining the integrity of Lisfranc joint. So we have two important joints in the foot, that is Lisfranc joint and Chopard joint. So Lisfranc joint is basically between the base of metatarsals and the uh, second row of the tarsal bones, distal row of the tarsal bones. So basically it is tarso-metatarsal joint. So that is Lisfranc joint. Chopard joint is joint which is formed between the hind foot and the midfoot. So that is talonavicular and calcaneocupoid joint. So in maintaining the integrity of Lisfranc joint, this Lisfranc ligament is very important, and it has three components. So it basically attaches the medial cuneiform with the base of second and third metatarsals. And if this ligament is torn, it can lead to disruption of this joint and abnormal widening and dislocation. So that is Lisfranc ligament. Let's have a look at the plantar aponeurosis, which is a hypointense structure which originates from the calcaneal tuberosity. And it has three components, that is medial segment, central segment, and lateral segment. So central segment, here we can see. So this is central segment which is originating from the medial process of calcaneal tuberosity. We have lateral segment and we have medial segment here. So this is the sagittal view, which is again showing plantar aponeurosis, which is a hypointense structure attaching over the calcaneal tuberosity. So it is important for maintaining the longitudinal arches. Muscles of the ankle and foot. Before seeing the muscles of ankle and foot, let's just have a look at the muscles of the leg, because these muscles are going to form tendons, and they will travel across the tendon and enter into the foot. So basically in leg, we divide the leg in different compartments, and we have anterior compartment of leg, which has tibialis anterior, extensor hallucis longus, extensor digitorum longus, and peroneus tertius muscles. Then we have posterior compartment, which is again divided into two parts, superficial and posterior. Superficial and deep posterior compartment. In superficial posterior compartment, we have triceps thorax, that is gastrocnemius, soleus, and plantaris muscle. In deep posterior compartment of leg, we have muscles which traverse in the tarsal tunnel, that is flexor hallucis longus, flexor digitorum longus, and tibialis posterior. And we have popliteus in the region of popliteal fossa. So all these muscles, they form the posterior compartment. Then we have lateral compartment of the leg, which has two muscles, peroneus longus and peroneus brevis. So let's just have a look at the origin and insertion of these muscles. So this is Tibialis, this is extensor hallucis. So this is extensor hallucis longus, which originates from the fibula and it attaches over the base of distal phalanx of the great toe. This is tibialis anterior, which originates from the tibia and fibula and inserts over the medial aspect of medial cuneiform bone. And this is the extensor digitorum longus, which splits in 4 tendons and traverses across the different phalanges and attaches over the base of distal phalanges of the respective toes. Then we have peroneus tertius, which is a vestigial muscle, and it is not very important, and sometimes it is absent in normal persons also. Then we have triceps surae, that is superficial posterior compartment muscles, which comprises of gastrocnemius, soleus, and plantaris. So gastrocnemius has 2 heads, medial and lateral, originating from the medial and lateral condyle of femur, and it crosses the knee joint and enters the leg, and finally it forms Achilles tendon and attaches over the calcaneal tuberosity. So it crosses 2 joints. And soleus lie deep to the gastrocnemius muscle, and it originates from tibia and fibula. Again, it traverses down and it contributes in the formation of Achilles tendon. So together, these gastrocnemius and soleus, they combine to form Achilles tendon. Then we have plantaris muscle, which originates from the lateral femoral condyle, and then it crosses towards the medial aspect of leg, and it attaches over the medial aspect of calcaneal tuberosity adjacent to the Achilles tendon. Then we have deep posterior compartment muscles, which include flexor hallucis longus, flexor digitorum longus, and tibialis posterior. So this is flexor hallucis longus, which originates from fibula and attaches over the distal phalanx of great toe. Then we have flexor digitorum longus, which crosses the ankle joint and divides in 4 slips and attach over the distal phalanx of respective toes. Then we have tibialis posterior, which again divides into multiple tendon slips and attaches over the multiple tarsal bones and base of metatarsal bones. Then we have lateral compartment muscles, which are peroneus longus and brevis. So as we can see, peroneus longus is originating higher up on the lateral side from fibula, and then it converts into tendon. This tendon crosses posterior to the fibula or lateral malleolus, and then it enters the sole of the foot. And after entering the sole of the foot, it attaches over the base of 5th metatarsal and the 1st cuneiform, that is medial cuneiform bone. So that is peroneus longus. Then we have peroneus brevis, which originates lower down from fibula. It traverses again posterior to the lateral malleolus, deep to the peroneus longus. So peroneus brevis is deep, peroneus longus is superficial, and it attaches over the base of 5th metatarsal. So this is the site where peroneus brevis attaches, and this is the site which is often involved by avulsion fractures in cases of inversion sprain. So let's have a look at these muscles on MR. So we are moving from knee to the ankle, and we can see these are the 2 heads of gastrocnemius muscle. This is popliteus. So these are all posterior compartment muscles. Here we can see tibialis anterior, extensor digitorum longus, and peroneus longus. And as we are moving down, we can see soleus, tibialis posterior, and flexor digitorum longus. And again, we can see flexor hallucis longus as we are moving down. So here we can see muscles of the posterior, anterior, and the lateral compartment. As we are moving down, these muscles will gradually form tendon. So here we can see posterior to soleus, we can see formation of the Achilles tendon over here. And here we can see peroneus brevis. This peroneus longus has already been converted into tendon, and this peroneus brevis is slightly fleshy. And as we move down, we can see tendon formation by all these muscles. Here we can see this is Achilles tendon. This is peroneus brevis, peroneus longus. These are tibialis anterior, extensor hallucis longus, and extensor digitorum longus. Here we can see tibialis posterior, flexor digitorum longus, and flexor hallucis longus. And we can also see this is the tibial neurovascular bundle. So here we can see all three tendons of the tarsal tunnel, that is tibialis posterior, flexor digitorum longus, and flexor hallucis longus. Here we can see two tendons posteriorly posterior to lateral malleolus, that is peroneus longus and brevis. Now let's have a look at the muscles of the foot which originate from the foot and insert in the foot. So they are basically confined to the foot and they are not crossing the ankle joint. So on dorsal aspect, we have two muscles, extensor digitorum brevis and extensor hallucis brevis. On plantar aspect, the anatomy is slightly complex and we have four layers of muscles on the sole of the foot. The first layer is formed by the abductor hallucis, flexor digitorum brevis, and abductor digiti minimi. So here we can see abductor hallucis, flexor digitorum brevis, and abductor digiti minimi. Second layer of muscles comprises of quadratus plantae and lumbrical muscles. So lumbrical muscles, they originate from the tendons of flexor digitorum longus and they insert over bone in the toes. So these are lumbrical muscles and this is quadratus plantae. Third layer is formed by flexor hallucis brevis, adductor hallucis, which has two heads, oblique head and transverse head. So this is adductor hallucis, and flexor digiti minimi brevis. And the fourth layer is the deepest layer, which is at the level of metatarsal bones. And so these are muscles, which interossei muscles, which are basically between the metatarsals. So on dorsal side, we have dorsal interossei, and on plantar side, we have plantar interossei. So let's have a look at these muscles on MR. So here we can see adductor digiti minimi, flexor digitorum brevis, quadratus plantae, and abductor hallucis. And as we move towards the toes, we can see quadratus plantae, flexor digitorum brevis, abductor digiti minimi. On dorsal aspect, we can see extensor hallucis brevis and extensor digitorum brevis. Here we can see this is the peroneus longus tendon, which is attaching over the medial cuneiform and base of first metatarsal bone. We can also see another important area, that is crossing of the flexor hallucis and flexor digitorum longus, that is knot of Henry over here. As we are moving towards the toes, we can see adductor hallucis, flexor hallucis brevis, flexor digiti minimi brevis, and adductor hallucis. We can also see lumbrical bones and the interossei muscles, which are between the metatarsal bones, and lumbrical muscles are between the tendons. So these are the muscles of foot. Now let's have a look at the nerves of ankle and foot. So in lower limb, we have one large nerve which supplies the entire lower limb muscles, and that is sciatic nerve. And sciatic nerve has two branches, tibial and peroneal, common peroneal branch. Tibial branch, it supplies the posterior and deep compartment muscles, and common peroneal nerve, it divides into deep peroneal and superficial peroneal nerve. Deep peroneal nerve supplies the anterior compartment muscles, which are extensor digitorum and hallucis longus and tibialis anterior and peroneus tertius. And the superficial peroneal nerve, it supplies the lateral compartment muscles, which are peroneus longus and brevis. So basically, common peroneal nerve is supplying muscles which are responsible for dorsiflexion and eversion of the foot. So if there is any injury to the common peroneal nerve, patient can present with foot drop. And the tibial nerve is basically supplying all the muscles in the posterior part of leg or the calf. This is a closer look of the common peroneal nerve, where we can see this is common peroneal nerve and its divisions, deep peroneal and superficial peroneal nerve. So common peroneal nerve basically traverses across, it's wind round on the neck of fibula, and from posterior to anterior, and anteriorly then it divides into deep peroneal and superficial peroneal nerve. This is the region of tarsal tunnel, where we can see the three tendons here and the tibial nerve and the posterior tibial artery. So this is the tibial nerve and its branches. These are the plantar, medial and lateral plantar nerve. And this is the inferior calcaneal nerve. So let's have a look at these nerves on MR. So here we can see this circle is pointing towards the tibial nerve, and these are the two branches of common peroneal nerve. And as we are moving down, we can see they are moving in their different compartments. So the tibial nerve will stay in the posterior compartment and will reach the tarsal tunnel, whereas the deep peroneal nerve will enter the anterior compartment or extensor compartment, and the superficial peroneal nerve will travel in the lateral compartment. So this is how these nerves travel in the leg and reach the ankle. So here we can see this is the deep peroneal nerve, this is the tibial nerve, and deep peroneal nerve will accompany the anterior tibial artery, whereas the tibial nerve will accompany the posterior tibial artery in the tarsal tunnel. So this was all about the anatomy, imaging anatomy of ankle and foot on radiograph and MR. And we also saw the osseous anatomy, ligamentous anatomy, anatomy of muscles, and anatomy of nerves in the ankle and foot. So that's all for today. Thank you.